this series of lecture, I will go with you through the radiology necessary for cochlear implantations. As you know, radiology is a central part in the evaluation of patients for cochlear implants. These are two lectures, one going through the normal anatomy and the normal requirements for cochlear implantation, and the second will be about anomalies and abnormalities we can face during our radiological studies, which may influence our decision and how we are going to manage our patients. Radiologic study is essential in determining the candidacy of the patient, the normal anatomy, the abnormalities which we can face, so as to properly plan our surgery. And this is the second role of radiology, to make a surgical plan beforehand so as not to be surprised by any unpleasant surprises. Third, we can monitor our surgery intraoperatively, especially if there are any anomalies or problems. And finally, in the postoperative follow-up of the patient, to determine the proper placement of the electrode and in the event of any problems or complications. Many imaging modalities can be used. The commonest are high-resolution CT scan and a non-contrast MRI. Cone beam CT is being increasingly used, especially in young infants, because of its rapid acquisition time and minimal exposure to radiation. Digital video tomography and plain X-ray have also their role depending on the situation. Contrast CT and MRI with special cochlear implant protocols are the routinely used imaging modalities, and both are complementary because each of them gives us certain information. Limiting imaging to MRI, especially in young kids, to minimize their exposure to radiation, but routinely I prefer using both the CT and the MRI because they give us additional information which help us in imagining what is happening and planning our surgery and any potential difficulties or complications. The images we have to think in a surgical way. So we recall the surgical steps and look at the radiological pictures, both the CT and the MRI, in this order. We start with the mastoid, the middle ear, then the cochlea, and then the cochlear nerve, and any other anomalies we can look for in the imaging. The first step in surgery is usually a cortical mastoidectomy. So the first anatomical element we are going to look at is the mastoid. We look at the pneumatization and development of the mastoid, the presence of any inflammatory pathologies, chronic otitis media, acute otitis media with effusion, or even cholesteatoma. And we look at the symmetry of the pneumatization of the mastoid, because if we are going to implant one side and audiologically there are no differences, we usually prefer to attack the more pneumatized side because it is easier for the surgeon and thus safer for the patient. Other important elements we have to look at are the anatomical variations, which might cause some difficulties and which may put some important structures at danger, especially the sigmoid sinus, the jugular bulb, the carotid, the facial nerve, a low-lying tegmen, or the presence of Körner's septum, which is a normal anatomical variation, but sometimes beginners may be lost and misled by the presence of a prominent Körner's septum. This is a well-pneumatized mastoid, and all the dimensions of the mastoid are rather favorable. And in these patients, we expect a simple mastoidectomy to be wide, large, without any problems or anatomical difficulties, which gives us a good access to our second step, which is the facial recess approach or posterior tympanotomy, and we do not expect marked difficulties. In contrast, if we look at this mastoid, this is a poorly pneumatized mastoid, and as you see, there are no air cells. This means that all anatomical landmarks will be hidden, and we have to drill out the mastoid very carefully to create a cavity which is expected to be narrow with difficult accesses to the middle ear through the posterior tympanotomy. So we are prepared beforehand for surgical difficulties and loss of the normal anatomical landmarks. We have to look out again for anatomical anomalies. For instance, in this patient, you can see that the sigmoid sinus is very prominent and the bone between the sigmoid and the mastoid is very thin. And actually, intraoperatively, you can see that the sigmoid sinus is denuded and is at risk of injury if the surgeon is not well aware of this. Again, the same thing, the sigmoid sinus is very superficial, and if the surgeon is not aware of this, he or she may injure the sigmoid sinus very simply during their drilling. Again, a very sclerosed mastoid with no landmarks and no space for drilling and for access through the posterior tympanotomy. In this case, you can see that the segment is very low lying, and if the surgeon is not aware that there are no air cells just medial to the cortex, you can penetrate this cortex and go intracranially without knowing that you are lost away from the mastoid. In this patient, you can see that the carotid artery is devoid of its normal bony covering, and it is traveling in the middle ear and can be readily injured if you are not aware that the carotid artery is exposed and that it is not properly running in its carotid canal. In patients with craniofacial anomalies, you can have asymmetries in the development of the mastoid. And as we said, if you are going to implant the patient unilaterally and there are no audiological differences, you will go and implant on the side with a better pneumatized mastoid because this makes life easier for you as a surgeon and with less complications for the patient. The second step in surgery is the posterior tympanotomy through the facial recess. The facial recess again is variable, and we have to look at its depth and angulation, at its pneumatization, and its access to the round window niche. The pneumatization of the facial recess is variable. In this patient with a well-pneumatized mastoid, the facial recess is also well pneumatized, and you can see that intraoperatively the access is very rapid and very direct, and we have a wide, simple access to the middle ear. On the other hand, in some patients, the mastoid is pneumatized, but the facial recess is sclerosed. And here we expect a lot of drilling, and we have to take very good care about the level of the facial nerve because it is at danger of injury during our drilling. In other patients as well, both the mastoid and the facial recess are sclerosed, and here we expect lots of drilling in solid bone, putting all structures at a danger, and we have to take very good care to avoid injury to the facial nerve or to the chorda tympani as well. The third step in surgery is access to the round window and access to the round window membrane through the round window niche. Again, the orientation of the round window, the development of the tegmen, and the development of the area around the round window niche are different in different patients. And we have to have an idea about the configuration of the round window from the radiology we have. Note different configuration of the round window niche. In this first one, the round window niche is very shallow and the tegmen is poorly developed, so we expect a direct view of the round window membrane through our posterior tympanotomy. In other cases, the tegmen is a little bit overhanging, and here we expect that we have to drill a little bit of this tegmen to have a good access to the round window membrane. And as you know, in these patients, you might have a false membrane covering this entry of the round window niche, and you might be tricked that this is the round window membrane. But if you know that the tegmen is well developed, you know you have to expect some drilling to reach the round window membrane. In other cases, the tegmen is so overhanging that it forms like an air cell hiding completely the round window membrane. And here you know that this access is very narrow, and you have to remove this whole part corresponding to this bony overhang until you can expose the round window niche. Is the cochlea. And as you know, each person has a unique cochlea, and actually both sides may not be symmetric. So we have a wide array of cochlear configuration, and we have to know this radiologically. And as you know, the cochlea has a bony shell and an inner soft tissue component with fluids and membranes and so on and so forth. And here is the first time we are going to look both at the CT scan and at the MRI to assess the development of the cochlea, its dimension, its orientation, the number of turns, the length of the cochlear duct, the symmetry of the scalar chambers, and the permeability of the scalar chambers as well. Looking at the various critical elements of the cochlea on the CT scan, the first thing we look at is the cochlear aperture, which is the opening between the internal auditory canal through which cochlear nerve fibers go into the cochlea, into the modalities, which is the bony core of the cochlea containing the spiral ganglion cells, which is the skeleton actually of the cochlea, and out of it are going the ramps of the osseous spiral lamina, which form the supporting elements for the basilar membrane. And then we are having a look at the basal turn of the cochlea and the middle turn of the cochlea and the apical turn as well in this cut. Because of the variability of the size and orientation of cochlea in different patients, we have to look at the cochlea at different cut levels to ascertain the presence and the configuration of the normal cochlear turns. This is the basal turn of the cochlea, this is the middle turn, and this is the apical turn. We can have a look at this cochlea as well to see that we have a basal turn, a middle turn, and an apical turn. Again, in this cut, we see part of the ascending limb of the basal turn, the middle turn, the modalities, and the apical turn. So to know if a cochlea is normal or abnormal, we have to look at it at different levels until we see all the components of the cochlea, because most of them may not be apparent on a single cut. After studying the bony configuration of the cochlea, we look inside the cochlea to look at the various scali of the cochlea and if they are present or not, if they are patent or not. As you know, each turn is divided into a scala tympani and a scala vestibuli. So on each turn, we look at the scala tympani and the scala vestibuli, and in between is the negative shadow of the osseous spiral lamina. Middle turn, again, we look at the scala tympani, scala vestibuli, and the scala tympani and scala vestibuli of the apical turn. So we have 6 levels of fluid-filled spaces in a normal cochlea. And we have to have a look at this on a T2 MRI to see the fluid content of the cochlea. When we are choosing our electrode, we have to adapt the electrode length to the cochlear duct length in which the electrode is going. And there are many ways to calculate the cochlear duct length, and this is the optimal way to choose the right electrode for each patient in order to approximate as much as possible normal hearing using the cochlear implant. There are some software features on some CT machines which can give you direct measurement of the cochlear duct length, but you can compute it by yourself on the easily available software and have an idea about the cochlear duct length. As you can see on this slide, the software of the CT scan can give us the length, the true length of the cochlear duct. It can even straighten it up and measure the whole length of the cochlear duct. And you know that depending on the length of the cochlear duct, you can determine the insertion angle and determine the length of each cochlea to choose which electrode is best for this patient. Only so, some software is now available in which you feed your CT scan data and the software can automatically determine all the dimensions and the directions of the cochlea and choose for you the best available electrode for each individual patient. And this is one of the good personalized medicine options available now. For electrical impulses to be properly conducted from the cochlea to the cochlear nuclei, we have to have an intact cochlear nerve. And this is the next structure we are going to look at in our imaging. As you know, developmentally, nerves are formed first and then the bone is formed around them. So when the nerves in the internal auditory canal are formed, the cochlear, the vestibular, the facial nerve, and the nervous intermediates are properly formed, we have normal dimensions of the internal auditory canal. And you can see on this CT scan that the internal auditory canal looks quite normal. It has a good diameter. You can measure this. You can see the configuration of the internal auditory canal, the cochlear aperture, and the opening for the cochlear nerve going into the basal turn of cochlea into the modalities. Again, we can look at the nerves in the internal auditory canal and in the cerebellopontine angle on a T2 weighted MRI. And again, you can have a glance of the normality of the cochlear nerve when we look at the MRI of the internal auditory canal. Looking at the CT scan first, you can have an idea if there is a problem with the nerves in the internal auditory meatus or not. This is again the normal configuration, but if you look at this internal auditory canal, you can immediately appreciate that this canal is very, very narrow compared to the other one. And if you can measure it, you can see that the canal is much less than the normal diameter of the canal. And you can expect that there might be a problem. Usually, the facial nerve is not affected. The vestibular nerve, being a very old nerve, is usually present. So when you have a narrow canal, you should expect first that the absent nerve is the cochlear nerve. As you can see here, we have an internal auditory canal which narrows significantly when it reaches to the fundus. There is no cochlear aperture, and there is a single nerve going out of the canal, which is the facial nerve. So at a first glance here, we can expect that there is a problem in the development of the cochlear nerve. One of the good cuts to look for the cochlear nerve is the axial T2 weighted MRI. As you know, the internal auditory meatus has two levels, an upper level in which we have the facial nerve running parallel to the vestibular nerve, and a lower level in which we find the inferior vestibular nerve and the cochlear nerve. As the vestibulocochlear nerve has a common origin, both nerves run close to each other and then they differentiate into an anterior cochlear nerve and a posterior inferior vestibular nerve. This is the Y-shaped configuration we look at when we are looking at the axial MRI. So we have a common stem, an anterior branch going into the cochlea, which is the cochlear nerve, and a posterior branch going to the vestibule, which is the inferior vestibular nerve. So On an axial T2 MRI, we can really appreciate the presence of the cochlear nerve immediately. We can see the same thing on an anterior cut of the coronal MRI, where we have the common vestibular cochlear nerve and the cochlear nerve going into the basal turn of the cochlea. Another useful sequence is the parasagittal cut, which follows the nerve from the brainstem through the cerebellopontine angle into the internal auditory canal, and we can here see all the nerves going from the brainstem into the inner ear, including the facial, nervus intermedius, the vestibular nerve, and the cochlear nerve, and we can follow them up and measure their diameters and compare the diameters to know whether this cochlear nerve is normal or abnormal. In this series of cuts, starting from the area of the cerebellopontine angle, we can follow the nerves from the brainstem into the cerebellopontine angle, and here we can see that we have 1, 2, and 3 nerves: the facial nerve anteriorly, the vestibular nerve superiorly, and the cochlear nerve inferiorly. And as we go more lateral, the nerves start to be more and more discrete, and finally, at the level of the internal auditory canal, we have this 4-nerve configuration: the facial anterosuperiorly, superior vestibular nerve, inferior vestibular nerve, and the cochlear nerve. So here we can appreciate the number of the nerves, and we can measure their diameters and compare the diameters. We usually compare between the facial nerve and the cochlear nerve, and if they are nearly the same diameter, we can assume that the cochlear nerve is normal. Looking at the MRI on the left side, you can see we have this normal 4 nerves configuration. But if we look at the MRI on the right side, you can see that there is something amiss. We don't see the 4-nerve configurations. We barely see only 2 nerves. And as I mentioned previously, when we have a nerve absent, this is the most recent nerve, and this is usually the cochlear nerve, which is absent, and we have the facial nerve and the vestibular nerve only. So this is a clear case of cochlear nerve deficiency, and when we are counseling the patients or taking the decision for cochlear implantation, we have to take very good care about these problems, and we see what we can do for these patients. We have gone through the imaging of the patient in a surgical strategy, and we are going to see what does this mean in surgical terms. Surgically, when you are planning surgery, you want to have a rapid view of what you are expecting. So what I usually do is look at these 3 cuts, and they give me a broad idea about what is happening for each patient. This is an axial CT scan, which shows me the pneumatization of the mastoid, the pneumatization of the facial recess, the configuration of the round window, and the anatomical configuration of the cochlea. The second cut is the MRI T2 axial segment. This shows me the configuration of the vestibulocochlear nerve, the cochlear nerve, the configuration of the cochlea, and the permeability of the cochlear scale. The third cut is the parasagittal cut at the level of the internal auditory meatus, which gives me the idea about the 4-nerve configurations of this patient. So looking at these 3 cuts, we have a primary idea about the bony landmarks, our surgical access, about the normality of the cochlea, and about the normality of the cochlear nerve. If you find any problem in any of these, you have to go back and restudy in full detail each and every cut of your imaging. And if you are not quite sure about what you are seeing, feel free to reorder a CT or an MRI or both. Never undergo surgery until you are 100% sure of your anatomy, because we are dealing with a very critical surgery. And if we are not sure about what we are looking for, there is no way to discover and get bad surprise. To sum up, we have to look at the mastoid pneumatization, at the facial recessed cellularity, at the round window niche configuration. We have to look at the cochlea and measure the cochlear duct length, look at the diameter of the internal auditory meatus, and look at the configuration of the cochlear nerve and its diameter. An extra luxury which can be provided by proper imaging is to choose the right size electrode, the right length electrode for each patient. And this can be available when you look at the CT scan, measure the cochlear duct length either manually or by the CT software or by special dedicated software, and try to choose, if you have this luxury, the best electrode fitted for this cochlea, so you get the best possible auditory results. Patients undergoing cochlear implantation may need imaging. This imaging may be due to CI related events or to CI unrelated events as well. We might need to image the patients immediately intraoperatively, postoperatively, or on the long term. We can use a plain X-ray, cone beam CT, or a CT, and this depends on the situation. Intraoperatively, you have to monitor your electrode placement, especially if you have problems in the electrical response during intraoperative measurements, or if you expect a difficulty, or if you faced a difficulty. Postoperatively, you might need to image your patients if there has been some complication or if there is deterioration in the performance of your apparatus. In some centers, it is routine to image your patient intraoperatively before ending your operation to make sure that the electrode is properly placed, it is properly coiled, and there are no problems. And here we have some intraoperative examples of plain X-rays performed intraoperatively showing the proper placement and the proper coiling of the electrode. Sometimes you are not sure, even with a plain X-ray, that everything is fine, and you might need a CT or a cone beam CT to look at the proper placement of the implant inside the cochlea. And this is an immediate post-operative CT scan showing that the electrode is properly placed and it is placed throughout its length inside the cochlea. Unfortunately, sometimes we can have problems, especially in patients who have been implanted and then you or your audiologist notice that there is a deterioration in the performance of the apparatus, and you image your patient to see what is happening. For instance, this young girl had a trauma to the head and the electrode started to be displaced outside of the cochlea, and as you can see, the electrode has been drawn out of the cochlea, and the performance of the implant was going down and she was not getting any benefits. Unfortunately, not all surgeries are straightforward, and sometimes you are faced with complications, especially if you do not get any electrical response intraoperatively and you are not sure that your electrode is properly placed. In these cases, you have to subject your patient to imaging and know what has gone wrong. In these examples, you can see that the electrode array is not properly placed in the cochlea. It was misplaced in many other places, and this is time to revise what has happened and see how we can correct these. Again, examples of implants going in the wrong sites and with poor response of the patient. And when we have a poor response of the patient, we have to image and see where is the electrode, what happened, and revise the surgery and respect that there is no response and that there is no improvement in the patient's condition. Patients with cochlear implant may have to be imaged, and imaging depends on what is their pathology and where are they going to get their image on the head and neck or in other parts of the body. The problem of the presence of the cochlear implant is due to the presence of the magnet and its metallic components. First, we are going to discuss what are the problems due to the presence of the cochlear implant. How can it influence imaging of the head and neck, especially the intracranial structures, and how it can influence imaging on other parts of the body, especially if the patient will need a CT or an MRI on other parts of the body away from the head and neck. When the patient undergoes a CT scan of the head and neck, the presence of the metallic components of the magnet will cast a metallic artifact from the magnet and from the receiver stimulating package, which may cause this sunray appearance, and it can obscure other important structures and make the CT scan unreadable in some areas. In patients undergoing MRI, the problems are much more complex. The metallic artifact will cast a large shadow on the side of the head and the brain, definitely, and it can obscure pathologies and limit the diagnostic possibilities of the MRI. Not only this, the presence of the magnet will be under the influence of the large magnet of the magnetic resonance imaging machine, and this may cause problems with the magnet itself. It can cause flippage of the magnet, it can cause displacement of the magnet, and this can occasion pain for the patient. And sometimes the magnetic interactions may lead to demagnetization of the magnet of the cochlear implant, leading to malfunction of the device. These are examples of what you can see with the cochlear implant in place. This is a CT scan. As you can see, the metallic artifact and the sunray appearance of the metallic artifact can deteriorate the quality of the image of the CT scan. In this patient, this was a patient with a vestibular schwannoma, bilateral profound sensorineural hearing loss, and she had to undergo cochlear implantation to help her. However, the presence of the cochlear implant means that she cannot undergo an MRI to follow up her vestibular schwannoma. So we had to resort to a contrast-enhanced CT scan to show and to follow up the progress of the vestibular schwannoma. But here, the presence of the cochlear implants leads to limitation in our diagnostic abilities in the proper follow-up of these patients. In this last patient, which is a case from the literature, again, a patient with NF2, which underwent a cochlear implant, and as you can see in this middle row, there is this big shadow from the cochlear implant, which has overshadowed the area of the internal auditory meatus, and the remaining vestibular schwannoma kept on growing, and it was completely masked by this artifact, by the cochlear implant, which led to problems for this patient. So the presence of a cochlear implant will make us reconsider how we are going to follow up our patient. Because of the problems with the cochlear implant with the MRI, various manufacturers have devised their own recommendations how to manage this, and most of the implants present nowadays are fully compatible with 1.5 Tesla MRIs without removal of the magnet. Newer implants, again, are compatible with the 3 Tesla MRIs, which makes life a little bit easier for us. Even so, when a patient with cochlear implant is going to get an MRI, there are certain things which must be followed. All external components of the cochlear implant system must be removed, and this might cause a communication problem during the MRI suite, and the operator of the MRI, the patient, and the caregiver must be in full communication to ensure that no problems occur because of the patient not hearing what he or she are instructed. Usually, we like to put a headband on the internal component to wrap it solidly so to minimize the effect of the magnet on the displacement and on the heat generated on the internal magnet so it is not displaced and it does not cause pain to the patient. Some authors recommend that the cervical spine should be anti-flexed into the chin to chest position to minimize the artifact and to minimize the movement of the magnet. And the patient must be instructed not to move the head sideways to minimize the interaction between the magnets of the machine and of the implant. And in some cases, in some glands, we have to remove the internal magnet before performing an MRI of the head and neck lesion. As you know, more and more patients are being implanted. Pediatric patients who have their whole lifespan and in which they can be in need of an MRI, and older patients which will definitely need an MRI for intracranial pathologies and so on and so forth. So we have to mitigate for this, and there are some tricks we can use when implanting the patients in order to minimize the effect of the presence of the magnet on head and neck imaging. We can change the distance from the external auditory meatus to the magnet to be more than 8 centimeters, put it a little bit more posterior and more vertically as well, so as to minimize the shadow which is cast by the magnet on the intracranial structures. And more manufacturers are changing the configuration of their magnets to be 3 Tesla compatible and to minimize their interaction and the shadow cast by this implant. This concludes the first part on imaging of cochlear implantation. The next presentation will be about abnormalities which we can face during the radiology of cochlear implants and how these abnormalities and anomalies can influence our decision for cochlear implantation.